Primary healthcare can be the staircase to a healthier tomorrow. While our world is becoming increasingly, primary healthcare remains rooted in the human-to-human connection. All have a part to play. Join the PHC movement future and achieve universal health coverage. Transform, thrive.
Okay, warm welcome to everyone who joins this parallel session 1 on strengthening of and moving from diseases to healthy people, healthy communities. So we hear very sessions today already, a lot about innovations, achievements. We saw in country experiences when we entering this in country vignettes. So we see that is growing demand from primary health care. And about primary health care, that it's not dealing with diseases, but coming more closer to social, economic determinants. It requires really innovative health service delivery. So that's where we are today, and we will listen one key questions that then we'll invite 4 countries for panel discussions. Afterwards, we give space for who came and are really motivated to change model of care. So space will be for you, a few minutes, and we will have 2 experts who reflect on our discussions. And we have to work very efficiently because it is tight. We have less than 1 hour. So I immediately honor to co-moderate with you Maria van Muijsenbergh, who is Professor Health Disparities and Primary Health Care in University, Netherlands. So, Maria.
Thank you very much, Arnoldas. I'm very honored to be here, able to co-moderate this session. I'm the chair of the European Primary Care, and our forum consists of over 100, all kinds of healthcare professionals, different disciplines, policymakers and researchers, and we aim to achieve good, affordable, good quality care for all people, and we do that by advocating for, are going to discuss here today, multidisciplinary, person-centered, community-oriented care. So I'm very happy to have the honor to introduce now to you our speaker, Dr. Rebecca Rosen. She's a senior fellow at the Nuffield Trust, and until 3 months ago, she was also working as a teacher, so she has first-hand experience and knowledge how we have to redesign primary care, the future, how we can achieve what we want this morning already. The floor is yours, Rebecca.
Thank you. It is an honour to be here to open this session. I'm going to put the next slide on. For any of you that need a Russian translation of this, you scan this, you will get to the translated slides. I'm just waiting. Are we okay now? So, if we are going to rethink the model of primary care, first we need to understand needs are changing. This slide illustrates the increasingly societies and communities in which primary care provides. They are characterized by substantial health and socioeconomic and growing cultural diversity. This is particularly urban populations. So on the right, you see the most commonly spoken language in the London boroughs, illustrating the diverse communities who must be met. And on the left, you can see the different socioeconomic of the city of Barcelona. As the most embedded health in local communities, Primary care practitioners need to understand and respond to these differences if they are to deliver effective and ensure that no one slips through the net. Increasingly aware of how social, economic and cultural factors affect health. A key skill of family medicine doctors who work at the heart of care is to interpret their patients' symptoms in the context of the determinants and adapt their response using both biomedical and paradigms. And while physicians are well equipped to address problems, we are increasingly aware that tackling the wider is best addressed in collaboration with a wider team, as we've heard this morning. So if we want primary care to evolve and address these fundamental determinants of population health, be sure to get the basics of family medicine right. You will all be familiar with the core values of primary care, set in the Marty Declaration, person-centred, comprehensive, holistic, etc. But we must also think of family medicine, which lies at the heart of care in terms of the functions that it has to cover. These illustrates 4 key functions of family medicine. Starting at the bottom, it must provide timely access for acute health. It must offer standardised interventions for prevention, such as and pap smears, chronic disease reviews. It must undertake care with other services for people living with complex and ongoing. And very importantly, the function on the right-hand side at 3 o'clock, family medicine needs to preserve the relational continuity, as several people mentioned this morning at care, that allows its doctors to know their patients. In the world of part-time working, at least to know and maintain a relation with complex patients with ongoing problems. It is through knowing that and their social and family situation, for example, that can interpret whether acute back pain needs an MRI scan, a symptom that always occurs in if a patient's home life deteriorates domestic abuse. The former needs a referral to hospital, can be demedicalised, and needs work with social workers and social supporters. And we have to remember that family doctors are working seeing pressure. Ageing populations with growing health needs, public expectations, health technologies, treatment options and new ways of working, and policy making more and more of primary care. We are making at a time when there is a global shortage of family doctors, when are wanting to work in new ways of better work-life balance, and when rural areas have very limited access to primary care. So we come to the first of 2 approaches that are central to the future of primary care, in which high-quality family medicine is intertwined with health professionals and other services to deliver a combination of preventive and public health initiatives and curative tailored to the needs of local populations and able to address social determinants of health. And we heard a lot about this morning. So there are many potential benefits of larger primary care teams, matching patient and population needs to clinical and professionals, opportunities to blend biomedical and psychosocial, increased capacity, increased access, opportunities to rotate team members between urban communities. These types of teams are increasingly across Europe and beyond. So how do we build on this trend? This graphic, which I'm sorry is difficult to read, is taken from a report being launched, which drew on case studies of innovative primary care countries, Estonia, Slovenia, England, the Netherlands. And the case studies showed us there is no blueprint professional primary care team. The list here shows people in the different teams in different countries. All the teams contain doctors, and beyond that, they have developed differently in each country and even countries, matching teams to local context, and they have a range of other clinical roles such as physios, and they have some non-clinical roles such as social workers and care coordinators, and some are part of broader preventive medicine and public health, or they include selected specialists such as paediatrics and gynecology. But what we also know is while there are benefits of working as part of a team, it is not easy to have a high-functioning team. We have to work hard from a team structure to a well-functioning professional. And this report is in England about introducing new clinical roles and new non-clinical aim to address the wider social determinants of health into the networks that we now have in England. I've learned that you can't just put people in the same room. You work hard to develop a shared vision and goals and values for the whole team, to design the roles carefully and to build relationships so that they work well together. A high-quality team, all supervision and mentoring from an experienced senior clinician, selected time so that they can operate safely. Setting up arrangements for peer support and professional is essential for job satisfaction and for retaining the team who are often having to work in new ways. So how develop these teams in primary locations that can take advantage of the benefits that they offer. A tiny rural clinic run by just one doctor is not going to be able to take on a whole new raft of professional workers. And that's where we're seeing real innovation in the design and scale of primary care organisations across the world. And this is the second approach, rethinking the balance between family medicine and preventive health, which was less talked about this morning. This is an image of the report that I mentioned earlier, which is being launched today, case studies of primary care networks and other larger scale primary care locations. It describes some of the benefits of working at scale. You can obviously read more. We've already talked about the potential to multidisciplinary teams and improve access as teams into hours. They have greater financial stability than a small, who are able to invest in innovations such as digital technology. They can support a management team to improve organisations and support organisational change and improvement. They can have buildings to accommodate a wider range of services, including urgent diagnostics. And again, there are no blueprints. Studies, this graphic is taken from the report, also showed us the many types of organisation that are emerging. Primary care networks through voluntary collaboration or through national policies and about what's happening in Lithuania. Mergers, practices to form larger organisations, municipals that employ clinicians in large facilities, primary care support organisations that offer resources, IT and management support to small practice work with, and chains of small clinics owned by a parent company. So for those of you here who are policymakers, how to encourage the emergence of primary care organisations that accommodate multi-professional teams and deliver the future version for primary healthcare, I'm going to describe this graphic very briefly. It sets out a three-stage practical approach to making these changes. Firstly, if you look at the line of talk really about the left-hand column here, that you need to be clear about the focus of the initiatives that will be introduced through an organisation that require family clinics to work in larger formations. The objectives for working must be clear, and they need to be meaningful to the professionals who are involved and to the needs of the patient population that will be. People aren't just going to come together without a clear purpose. They're a trigger factor, such as a funding opportunity or a crisis. We have a crisis in England, and we have to address it through thinking about these changes. But they must be clear, and they must be relevant. Mechanism or policy levers for change, which are most appropriate being the agreed goals. This may include new approaches to contract and also use of regulation and standards of practice that are achieved through larger organisations. And third, support scaling up. These are essential, as without in small clinics will not have the time, the energy, the skills, or this kind of change. So there must be investment in organisational, in team building, and more. You can read more about this, but in this presentation there is only time for a taster of this approach. Now I'm going to hand over to the panel to tell you about the initiatives which will bring these ideas to life. Thank you.
Thanks, Rebecca. This was very to the spot, how we can still in the future address all the needs of a changing social economic disparities and diversity, and some multi-professional teamwork in innovative is excellent. Now I will hand over to Arnoldas to invite the panel.
It's a pleasure to invite you, and as I mentioned, we will have 4 countries and co-host of this event. First, Ministry of Republic of Kazakhstan, Dr. Timur Sultangaziev. With Dr. Daping Song, Dean of Health, Law and Social and of the of China. Also, it's a pleasure to invite Ramosacaj, Deputy for Health, Ministry of Social Protection, Albania. And in Afzaal, Deputy Director, Health Systems, Ministry of Health. We start from our host, and today a lot talked about Kazakhstan achievements. We really boost accomplishments in terms of primary healthcare transformations to services closer to the people, and includes coming to better understanding of population health needs, not only biomedical but more holistic, that also better social needs, and coming closer to social economics. Countries are eager to come to Kazakhstan now to learn. And also have today in the opening, it's recognized that His Excellency President of Republic of Kazakhstan also opens this with recognition, high recognition of role. So I think that's what we talk and prioritize, that primary healthcare have to be agenda of highest policies to reach social cohesion, equity, social well-being. That already you are done very close in this intensive transformation during last 10 years. So Dr. Timur Sultangaziev, so what were the main transformation? What dimensions were in transformation?
Thank you very much. And first of all, welcome everybody once more, and participants for this active discussions. Today we're discussing the transformation of primary health in accordance with the framework that was declared during the Declaration and Astana Declaration, and we've seen huge achievements have been made throughout many, as well as in my country, Kazakhstan. Assessing of the primary health care, our model is based on the very definition of health itself. Tells us that the individual should experience not only the physical well-being, but also social and physical well-being. And therefore, we all only 10–15% actually affects the health of the individual person through medication, new technologies, but the rest depends on the lifestyle, environment, different determinants, like what food we eat, what clean water we drink, or else. So in this regard, we understand, first of all, that the multidisciplinary teams as a groups of clinical and non-clinical specialists, not only medical personnel as a general practitioner or a family doctor and nurses, but also psychologists, pharmacists, and other specialists. So for the non-clinical specialists, including mental health care workers, were introduced in primary healthcare organization in Kazakhstan in 2004. They were primarily assigned to health centers, providing support to teenagers with difficult situations, life situations. Experiences has given us the understanding that we need the medical and social support for the entire. Therefore, in 20, so-called Salamat Kazakhstan program was officially integrated social work and psychologists into the staff of primary healthcare organizations. And the ratio was 1 social worker, 10,000 population. And training programs has been launched, and all the patient at primary healthcare level went through certain trainings. At the same time, it's the teamwork of clinical specialists that has proven to be effective within the management program, which Kazakhstan implemented in 2013. To manage disease effectiveness of the program was placed on a comprehensive assessment of patients' conditions. So then we, at that time and now, with several levels of multidisciplinary teams. The first level includes the primary care physician, nurse, social workers, and mental health workers. And the second level differs in that specialized experts based on the specific disease. For example, in our case, for the disease management program, we chose chronic heart insufficiency, diabetes, hypertension. So in that, certain necessaries like ophthalmologists and endocrinologists and other specialists would be in work. And analyzing the results, we observed that by the multidisciplinary specialists have higher quality of life. And this holistic approach we speak of gives us a sense of care and understanding of their needs. And also we, after the introduction of these multi-teams, we've been able to reduce urgentation of those who were under this patronage. And still, we understand that the family physician at the lead of the multidisciplinary teams. And in order to free up their burden, I mean, the work, we tripled number of, right now it's 3 nurses per 1 family, and almost 20% of medical duties were delayed for preventive examinations, dynamic observation. And today we have regulatory paperwork, such as rules for primary health care. We have a standard for the delivery of special services in the healthcare. And between 2022, the number of social workers went up by 2 and 2.5 times respect. And especially during the COVID, where all the healthcare systems were a huge, unprecedented amount of pressure, these multidisciplinary were formed, mobile teams were formed from multidisciplinary teams from primary health. And those specialists were going to the patient home, providing not only medical, I mean medication, also social and psychological support for the patients. Recognizing the importance of the multidisciplinary teams, we now have at the regulatory basis 1 mental health care worker and social worker per 5,000 patient population. And we have 48 so-called centers for best practices country, and those are the disciplinary teams that plays the leading role in that organization. So, sum up, okay, thank you very much. Today's discussion will motivate us to work together, better future of primary health care. Thank you very much.
Thank you. And really, we with multidisciplinary teams, we see how to population, how connection with people happens, and people in self-management and so. But how we know who's help, how we know who is vulnerable, and how we this. So today is a lot of use digital technologies. Looking to you, Dr. Song, we well know how China is investing in information technology in healthcare. And can you share China shortly, before talking more deeply about model, just digital technologies is used to identify population health needs?
Yes, of course. Thank you, Arnoldas and Excellencies. It's a pleasure to share some example from the local across China on digital health. We have a Jinhua municipal of Jiangsu province. The real-time health data detected by wearable devices, blood pressure and blood sugar, can be automatically filled in electronic health records and sent to their family doctor. And also in Fengxian County of Jiangsu province, the of blood pressure, blood sugar, and precise health education information is sent to the patient through the WeChat app. A visualized NCD map with geographic information indicating high risk of occurrence of NCDs in 13 counties of Zhejiang province. And smartphones are established in many localities in China, as well as appointments for door-to-door drug delivery.
Thank you very much, Dr. It's how you manage to get all this data and put them into good use services to the needs of people. Now we are talking a lot about that are very important, but of course sometimes technology to take us away from the basics of primary care. I'm very happy that we have with us Dr. Sabeen, and she probably you can tell us a bit more about how Kazakhstan is your new integrated service can address the basics of primary health care.
Thank you for giving me this opportunity. Primary healthcare, as you know, is the basis of and foundation and a way to reach the communities. So what Pakistan has actually that we have developed a very essential package of health services, DCP3 translation. And then we have added and piloted it model, PNC-oriented model of care districts in Pakistan. The both districts have their qualities and differentiality, and these packages that we have developed, they are provincial and regional specific, addressing the needs of different people. If you go across Pakistan, there is diversity, culturally, language-wise, geographically, lofty mountains in the north and almost desert in the south. So those packages were developed, and then the PHC model of care were implemented, so we can give holistic quality of care. Along with that, to address that, HR was an element. So we have a network of lady health workers, which are more around 100,000 of them across the country. So and their training manual were revised, and they have been trained. Being part in the community, they can address the primary health of the community. At the same time, parallelly, with the support of WHO, we have universities who are offering a one-year diploma only medicine. Although the fellowship program was actually involving GPs, the general practitioner, medical officer working at the primary health care has added. It was introduced around in 2021, so and almost 200 people have now. This course is actually being recognized by the country. So, and then providing certain refabrication, basic medicines, equipment at the primary, make it more functional and then at the community. Thank you.
Thank you very much. I think it's impressive that you have this tool, the network of community health workers, the lady network, very nice. Also strengthening the competencies of the professionals. I think we can learn a lot of that. Very much.
Thank you, thank you. Now let's move to Albania, Entela. And I remember 7 years when I was first mission in Albania. We visited emergency department of hospital, which was full of patients with lot even waiting out. And we together with ministry discussed, and that is because performance of primary health care is mission. And you started, launched a comprehensive health care reform. Can you shortly, as possible, discuss what was key elements of this transformation?
Thank you, Doctor, for giving me. It's very important to me to talk about how the care system in Albania has been transformed during years. Well, I'm proud to say that many strategic objectives set in the programs of the Albanian have been achieved during the last 8 years through public fund for health, through designing and implementing disease prevention programs, expanding accessible treatment, and improving the healthcare centers. Of course, this is to better address population needs and to have more accessible and equitable primary healthcare services. On 18, with the decision of the Council of the Ministers, a new structure was created. It was the National Care Services Operator. Through its 4 regional and local healthcare units, the agency now functions in healthcare planning and administration, management of human resources. Years ago, our government decided to shift focus expenditures to investments and from disease. That's why, in this context of the increased investments, the national program of all our primary health care centers, 400 centers, was launched. Program, all the health centers are already and upgraded. As part of investment, we managed to increase salaries for doctors, and in the recent years, we managed to raise them by 63%, and we managed to increase them again by the beginning of the new year. In recent years, the Ministry of Health and Social has taken measures that the allocation of healthcare expense is more efficient and sustainable by shifting more resources here, for example, in disease prevention. That's why managed to design and implement some programs, such as one of the largest is the health checkup for more than 2.5 million citizens. We have a population of 2,100,000 citizens living in Albania. So this is the program that aims not only to also to early detect some of non-communicable diseases. Quality and efficiency of services is another component of universal health coverage, which years has included new initiatives and comprehensive reforms, such as starting the process of adapting standards and basic medical protocols in all primary healthcare. And also we have established computerized system in terms of referral system, recommendation, electronic prescription, electronic signature, and so on. So we have strengthened our program like breast cancer, like screening programs, and also dental care, vision care for children at school. Last year, we started to create most of our primary healthcare centers did healthcare services with psychologists. So we created like teams, not only with doctors and nurses, but also with social workers, psychologists, speech therapists, and therapists. Because the country had some issues regarding mental and non-communicable diseases, that's why we created social and healthcare services. But as we mentioned during all those sessions, above all these programs, we have established the relationship between doctor and which is very important in these moments. Thank you.
Thank you, thank you. Really impressive reform. Also following like Kazakhstan, also that you expand with psychologists, social workers that to come close upstream needs and psychosocial needs. Let's go back now to China. They talk digital transformation and use for understanding those needs, but they also implemented very intensive to the networks, scaling up services country, and that was done in relatively short time for such country like China is. So Dr. Song, describe main priorities what was formed and what allowed to scale up services so quickly.
Okay, thank you. Primary health is always the foundation and focus of China's health. Firstly, the PHC network has been established, proving. So as we all know, from the 90s to the 1970s, China has established a tiered healthcare delivery network at county, town, village, in rural areas. Entering the new century, it kept improving the healthcare delivery network in urban areas. Now, the number of grassroots health facilities accounts 5% of all health facilities in China, and over 90% of households can reach the nearest point of healthcare in 15 minutes. Secondly, basic public health services and tailored simple medical services are provided by families. Since 2009, China has provided public health services such as health education, health management for special groups. The services are provided, especially to the elderly above 65, under 6, pregnant women, and patients with type 2 diabetes. The services are provided by family doctors as the free package. At the same time, many localities developed paid packages for simple medical services, such as in Daping County of Jiangsu Province. The paid for patients with hypertension, there are many for NCDs. We have this small package. The small package is cheaper. So for this, the services include fundus photograph consultation by experts from upper-level hospitals and so on, which over 25,000 patients in 2021, 4% of the population of that city. Thirdly, China health services closer to people. On the one hand, it is close minor conditions treated within the village. These are treated within the township. Major diseases are treated county. Above county, we have municipal and national. We have these layers. Such as in the county of Anhui province, high-quality medical resources used to grassroots health facilities as the benefit of medical consortium. The consortium is a unity of county and village health facilities located within. Social health insurance pay the consortium in rather than fee-for-service to each health facility before. So with the impetus to plus measures such as two-way referral is from hospitals to grassroots facilities and be made by county hospitals to help township health centers are really easy to scale up. Famous experts outside the county are also invited. On the other hand, it is services expanded from medical services. In the same county, outpatient services for patients with NCDs by social health insurance and the Fund of Basic Public Health Service in capitation. When a grassroots doctor medical prescription, a health management prescription is also including diet, exercise, and emotional management, and so forth. Last but not the least, the prevention of multiple diseases at the same time, and one-stop promoted. In Shandong province, NCD management system has been established and known as the management of 3 hypers and co-prevention of 6 so the 3 hypers are hypertension, hyperglycemia, and hyperlipidemia. The co-prevention of 6 complications from these 3 hypers, such as diseases, stroke, kidney disease, fungus, they are co-managed. In Zhejiang province, emphasis on treatment of NCD, only treatment, expanded to pre-treatment and post-treatment with the aim of pre-diagnosis management, examination, treatment, and follow-up into the outpatient general medicine. Thank you.
Thank you. Thank you. And that really arguments about how with this reform you reach and you really reduced equity, increasing outcomes, especially for vulnerable population groups, and increase access to primary healthcare services is published. And I want to all of you that there are, if you visit virtual linking to parallel session 1, you will find a link published resources which related to the model of care, which was from China, and several publications from European region. We now, with time, are quite pressed, so one question allowed, but in parallel, I want to introduce our experts who reflect on the panel, the presentation, and to your questions, if any. And I first would like to introduce Nigel Edwards, a fellow of London School of Medicine and Hygiene, and director of Nuffield Trust. So, and also second expert will be acting director of Gender Inequalities, Human Rights, and Health Equity, Erin. So I see, so maybe it will come later. Okay, one question, please. Introduce yourself.
Okay, health, that's different. Okay, so I really want to have more health promotion. And what we need, at least in Austria, is to educate us to understand health promotion at all. Usually they only look at treatment and sickness, disease, as in the title of this session.
Thank you for this question. So let's give floor, my proposal that we give to Nigel Edwards, and I ready to respond to the question, but after Nigel's actions. And if some of you would like to respond to the question, also most welcome. After, yeah, please. After Nigel. After Nigel. You touch more.
So, quite a number of common themes from what we've heard I think are worth picking out. One is being very clear about of why you are building broader primary care teams and to achieve. And those objectives seem to be drawn quite, may well include health promotion. And of course, bigger scale allows you to have to encompass within the primary care different perspectives, almost different philosophies of how your task, which is you're quite right. I mean, I think training family to do primary health promotion is probably not the best way forward. But the Slovenian case study in this report, for example, shows how in these larger scale teams with the public health function offices to bring in new perspectives and new disciplines into the mix. So point one, clear objectives. Point two, bigger, more capabilities to be able to do things and do them in different ways, new people into your team. And the other components of that we've heard in a number of the contributions has been the growing importance of mental health as part and indeed support. So the patient in their broadest context and not just the biomedical of care that we've had. Another theme that's really important here is needs of the population and fitting your model to the context in which, and I think the growth of digital technology, like we've heard in China, we'd have people from Spain here, we'd also hear about the ability to risk stratify the population and really understand how to structure the team to meet the population. And that is why the point Rebecca made is very important. The formula here, we cannot give you a set of norms that say you need people doing these different roles. What we heard from Rebecca, which I think is we didn't from the panel, but I suspect they might want to comment on it, is the turning to work in new ways in teams is not. It requires time and effort. You're developing new relationships. You're developing new work processes and ways of working. All of it requires investment in change management support for people to make the change. You cannot make these changes just making a few adjustments at the end of the day, having a little meet it down and think hard about how you're going to do it. Perhaps a couple of final points. Some basic things require attention. There's a multidisciplinary team if you don't have a building in which the members of your members of staff, you can find it very hard to coordinate care if there is not a shared paper record, but hopefully it's a digital one. But you need a way of understanding what you're doing. So how activity is recorded and how information is captured is important. Paying people the right salaries, but I think fundamentally on a firm foundation of strong family medicine, well-trained, well-supported and properly rewarded for the work they do. If you do all of that, there is opportunity to have a wide focus, a variety of tasks and activities embedded in these big teams. There's lots of different disciplines, but we shouldn't underestimate the size of the challenge to make this work and indeed that it takes. If we listen to the examples we've heard, all of them by the fact that this has been a long development process. So a degree of reach to policymakers about how quickly you can do this will be very important. I've gone on too long. I must stop. Thank you very much.
Thank you, Nigel. As promised, response to the question partly already was covered by Nigel, but Dr. Sabeen.
Yeah, I agree with Nigel. You cannot give every task to the doctor. So in our setup, we have given the health promotion bit to lady health worker. The health community, they speak same language, they practice same socio-cultural behavior. Listen to them more than to a doctor sitting there. So like multidisciplinary team, people hailing health.
Yeah, yeah, thank you. As a family, just to add from myself that in my practice, I think good in individual interventions and brief interventions, but but to get synergy and to community priority problems, we need to work together with or as Dr. Sabeen, we have to have in team some who health promotion, health education specialists, and that, for example, is Kazakhstan, where in every primary healthcare center is health education center who work in health promotion, and so multidisciplinary team and scaling up is possibility to achieve this more health promotion to priority health needs. So, Dr. Erin, so is floor yours for expert reflections.
Thank you so much, moderators. Thank you, Rebecca. And thank you to the excellent panel. I'm going to pick up on one other common thread, the big one for me. People, the people who provide the care and the fit from the care. And Rebecca started us off talking about compassion, clearly based in the drive for health equity. It's based on everyone's fulfillment of the right to health. And with that in mind, the focus has to be, as mentioned, on those who are really being left behind. We have to make sure on people who are facing marginalization, discrimination. And I think for that, we talked about social participation, making sure that they are involved in decision making, and we need to look at the barrier, keep people from accessing the care, and that comes with data, disaggregated data. It comes with looking at barriers analysis, and it comes from the social. But I want to add one more thing. Gender norms affect care. They affect access to care, gender norm uptake of care. And they affect, we have to think of gender in the health workforce as well, in terms of pay and conditions, in terms of mutual respect in place. These wonderful multidisciplinary teams that we have to consider how gender plays a role in these teams, make everyone benefit from really looking at those aspects as well. When we do that, and we see the great work that's happening in country, then we go to a place where we have culturally appropriate, gender, human rights-based, disability and inclusive, equity-oriented primary health care that I think is after. So thanks again, and thanks for a great panel. Thank you.
Thank you very much. I think this is very valuable into all the other very important things that have been said in this session. I'm afraid I see one finger. Are we allowed to remark from?
Maybe first negotiate that it will be like short.
Very short, yeah.
This morning that I'm able to use the time. I want just to add one excellent summary. That is that more and more we try to interact with the patient, the life goals of the person. Because what we very often miss, we have our targets and we have our evidence, achievements of objectives that we have to achieve. But of course, the patient has a life goal. He wants to achieve that matters to him. So, and until now, we focus too much on what is the matter with Mrs. Johnson, with what matters to Mrs. Johnson. And we are shifting the paradigm towards that, and that gives a dramatic, positive to the consultation. Because even go about shared decision making, now if you're still biomedical goals and targets, that will, and I think that this is the next level. We have to go to that. The patient is in the driver's seat. That means her life goals are really what has to be achieved. And we know also are going to try to integrate that in the electronic medical record so that all the episodes of care that are registered are linked goals of the patient. And that gives a completely new perspective. Now in a conceptual phase, but I think that that's the way forward. Thank you.
Thank you very much. I couldn't agree more. Now we've come to the closure of this session, and I just want to try to summarize what we've learned. We have learned that to address also the complex and increasingly diverse relation to achieve equity, economic diversity, as well as gender and other forms of diversity, we really to have worked compassionate, multi-professional teams who work in innovative healthcare organizations, which is not easy. It will cost time and money and also training. And those teams, they have to do person-centered, so not only biomedical, but also psycho-oriented, like Jan said, care and integrate with public health and social care in order also to address the health promotion. In the examples of 4 very different and large and important countries that it's possible to really reform the system. We've seen that it's possible to really to the population health needs and that technology can help us about those needs. And we see that care workers are very important to reach out, especially who are most ignored in our and in order to provide health promotion. And that has to end with training of the workforce, of the profession. And then we see that it's very, very important sufficiently, because that's, I think we sometimes, sufficient funding is really the basic of bringing primary care further. And we have also seen that it is possible by grassroots service, and that's when then we are about, it's about people, it's about the patients we want to help, it's about the people working in this wonderful profession of primary care. Together we can make sure that we are not leaving anyone behind.
So thank you all who were participating here. And of course, understood in this session that there are a lot of solutions have to put more on the shoulders of primary care. But how to manage to fulfill this expectation of people and to address their needs. And the solution in different contexts. And we heard today more explanation of 4 different countries. Thank you very much. I kindly remind that you can read more in again, if you want to repeatedly to hear it, in our virtual platform, linking to the. Many thanks to 2 experts, Edward and and applause. And to all of you and Peter, Novation and intervention, Jan, for your intervention, which was very useful. And, yes, and let's continue in immediate move to the next panel number 3 in the main hall.